So you've asked me to summarize my professional biography, as it were, in one sentence if I can, and I'll give it a try. For the past 22 years, I would say I have been helping organizations to either prepare for a Joint Commission or CMS survey, or helping clients to rebuild their programs after a failed survey. Now, throughout my career, I have witnessed four main organizational weaknesses that are consistently threatening an organization's patient safety effectiveness, threatening their Medicare reimbursement, or of course jeopardizing their accreditation status. Now mind you, these top four obstacles are not highly technical or clinical in nature, but rather structural and process driven, that have a direct impact on the connectivity of documents, connectivity of performance data, and the connectivity of leadership work groups and their committee functionings. Now, of course, our 120 document patient safety collection is fully integrated, focuses on all the needed clinical and technical processes for error and injury reduction. But the four obstacles I'll present to your audience today are infrastructural obstacles that must also be overcome, in addition to having the current plans, policies, dashboards for your patient or their patient safety program to yield measurable results. Now, I've given a name to describe these four obstacles that are preventing healthcare organizations from reducing hospital-acquired conditions and infections. It's an expression we have all heard and probably have used when a mistake happens. That expression is, "Oh, damn." So let me first describe what "oh, damn" means, and then we'll go through each of the components of that. Now, O from "oh, damn" stands for outdated. D stands for disconnected. A stands for anonymous. And M stands for money. So if you'll allow me to briefly elaborate on these four most common obstacles that have driven our companies since July 2002, when the National Patient Safety Goals were first introduced, and we've continually updated and refined them ever since 2002, which resulted in what we're offering the healthcare community today. So now bear in mind, one of the following shortcomings, any one of the following shortcomings alone will prevent a patient safety program from achieving maximum yield. Multiple program obstacles within "oh, damn" will compound your limitations. There's no question about it. So let's begin with outdated, the O in "oh, damn." Now, outdated patient safety plans, policies, performance measurement indicators or dashboards, and outdated staff orientation, training, or education tools. This obstacle will definitely yield a program that's not current and therefore not to its maximum effectiveness. So let me say this without question. Outdated or incomplete planning documents will automatically translate into outdated, incomplete staff and leadership training, because the leaders of the various committees, be it the Quality Management Director, P&T Committee, Environment of Care, Quality Council, MEC, you name it, these folks need to be guided by the most current documents that are available. So there's no mystery there. Of course, the staff have to be trained because they're the ones who are performing these activities, clinical, to minimize falls, to minimize medication errors, to minimize surgical site infections. So at the heart of being outdated is what we do well is that when the regulations change and we generate new policies or update our existing policies, we ping right back to the orientation education program materials and update those so they remain in harmony. Okay? So that kind of covers outdated. Now the D in "oh, damn" stands for disconnected. Now, either disconnected data, disconnected information, which is not the same, disconnected staff training, disconnected policies, or your reporting structures through your various committee activities could also be a vulnerability, and quite often is. So, listen, everybody knows the axiom of you can't fix what you can't measure. Okay, I get it. But what's often neglected in complex organizations is that once the data is swept up and collected, the resulting information doesn't quite get consolidated and targeted and shared with the right committee or leadership group at the right time. so that they can do the right thing and act on that data, which must be accurate and it must be complete. Because if they're getting incomplete data, their actions will be incomplete. Now, admittedly, this becomes unnecessarily complicated. I see this in facilities all the time, where they've got 10 or 12 different performance measurement dashboards going to 10 or 12 different committees. That's a complication. It's an unnecessary one. We get it, and that's why we offer a better way. Now, the next letter in ODAM is the A, which stands for anonymous documents from multiple external sources that ultimately result in what we call a patch quilt. So the short version is that it has been proven time and time again that bringing plans and policies from your old hospital, or getting them from a friend's hospital, or going online to an anonymous blog or a forum, always seems to result in a patch quilt of disconnected documents. They weren't developed by the same individuals, they weren't developed for your organization, therefore you can't expect them to seamlessly come together for the good of your organization. So it's not an integrated system that you need to succeed. Now, shamelessly I'll say that the integrated relationship between all of the documents, of the 120 documents in our patient safety collection, are just that. They relate to each other. They were designed for organizations anywhere from 200-bed hospitals to 800-bed hospitals, all of which I've visited many in the 44 states and the 1.6 million miles that I've traveled since 1988. There's a lot more detail, by the way, we have a document display video, which is another recording in our patient safety series, and perhaps you can encourage your viewers to go take a look at that, because within that second video, we demonstrate in much greater details everything associated with both coordinating organizational structure and the perils of the patch quilt. So lastly, that brings us to the M in ODAM, which is money, as I mentioned before. Now, to understand the potential cost of non-reimbursement for care associated with hospital-acquired conditions and the need to be agile and reprioritize improvement targets, why don't we begin by me sharing with you just the scope and some of the cost statistics. Now, according to CDC, there are 1.4 million hospital-acquired infections per year that require additional treatment or care to address this acquired condition. Now, the unplanned treatment results in an unplanned increased length of stay, on average of 7 to 9 days. Now, that's quite a bit. I think before we get too much further, it's important to note that of this 1.4 million hospital-acquired infections, 98,000 Americans die from these infections each year. Now, these are preventable deaths. Now, if we calculate 1.4 million hospital-acquired infections and divide that by 5,800 hospitals in the United States, that would equal on average about 240 HAIs per year. Now, of course, this is not a linear equation. I understand that, because some facilities have less, some have more. But the key point here is, I have never worked in a hospital or read or heard of any hospital that did not have any hospital-acquired infections. So it is genuine. It's a genuine issue going on in healthcare today. Now, in terms of dollars, the average cost of just one hospital-acquired infection is $13,900. That's to reverse the effects of this infection that was acquired within the hospital as an inpatient. Now, if we extrapolate that cost and apply it to the 240 average hospital-acquired infections for the formula I mentioned before, the cost of that hospital would be estimated to be $3.3 million. Now, that's real money. Now, it's also important to recognize that for a variety of these infection types, the cost is not reimbursable by Medicare at present. And lastly, what's not to be ignored is that $13,900 does not even include the additional costs that are borne by the patient and their family after discharge. Now, I mentioned that the Medicare Never Event list we're all aware of, or at least the clients that hopefully will be seeing this are aware of. But there's a new footnote to this. It was announced in February 2011 that each state will now be able to expand beyond the CMS never event do not pay list, and therefore add additional hospital-acquired conditions that will not be reimbursable by Medicaid. So considering that 49 out of the 50 states are running budget deficits, it's bound to happen that each state will further reduce Medicaid reimbursement from this point forward for hospital-acquired conditions. It's starting to get serious now. Now, and here's my shameless plug. Since 2002, we have been developing and updating our patient safety collection to reduce all hospital-acquired conditions, including infections, falls, medication errors, blood administration errors, and other preventable conditions. And our collection costs less than $800. So, I guess to conclude, let me say, the risk to value equation brings me to the final fact that if an organization eliminates just one hospital-acquired infection by using our integrated patient safety collection and saves $13,000 or saves a life, then the hospital and the patients both win as a result of our 8 years of development and refinement on this particular collection. In essence, there is no chance here. With our updated and advanced patient safety collection, there's no chance that your program's not going to get better. Very few hospitals have had an individual dedicated for 8 years to refine a collection. And I understand why. Their lives are quite full. Patient safety officers, quality management directors, risk management directors, infection prevention specialists, they've got full plates. Not to say that I don't, but it is my job to continually update and refine. Lastly, I would encourage your viewers to visit Hospital Policy Net website and view this document display that I mentioned before, because it goes into a lot greater detail with examples of organizational structure, details about the patch quilt phenomena that I mentioned before, as well as portraying a number of sample documents from the 120 document collection that we offer. I thank you for your time.